अरे विनोद ಒಬ್ಬ ಬರ್ಬೇಕು ಅನ್ಸುತ್ತೆ. He has not joined in. No one else is joining, no?
No, sir. That's all I think. From us, all of us have joined, sir. Otherwise, other than
Okay.
Vinod.
So I think we will start then.
Hmm.
Okay. Good evening, everyone. Today I'll welcome you to the Journal Club. Dr. Praveen will be presenting a paper on extended right hemicolectomy versus right hemicolectomy for right-sided colon cancer. Praveen, you can start off.
Yes, sir. Good evening to everyone. Today paper on discussion will be extended right-sided colon resection increases the risk of post-operative complications and does not reduce the risk of colon cancer local region recurrence, which is a nationwide population-based study from Danish colorectal cancer group database. The author of this paper was Ala El Husanna, which was published on 10th of March 2022 in Disease of Colorectum Journal with the impact factor of 4.567 and SGR ranking of 1.005. Resection
What
of
is
right
this
side.
SJR ranking, man?
Sir, it is a same-ago journal rank, sir. It gives the prestige of journal, that is quality of journal, sir. And if it is greater than 1, it is above average citation potential. And if it is less than 1, below average journal, sir.
I had never heard of this. It's the first time I'm hearing this.
Apparently, Lakshman sir wanted it to be
Lakshman,
put
sir,
last time.
What is SJR full form?
sir, same-ago journal rank, SCIMAGO, sir. It is average number of weighted citations received during a selected year per document published in that journal during previous 3 years.
Okay. Okay, right.
Resection of right-sided colon cancer has many refinements, such as there are many invasive access to abdominal cavity, such as laparoscopic, single incision laparoscopic, robotic assisted, and various anastomosis techniques such as extracorporeal versus intracorporeal, stapled versus hand-sewn, momental patch versus no patch, and high-tie or complete mesocolic excision. It is still debatable whether the complete mesocolic excision surgery is among the factors that contribute to increase in survival rates or not. And the right hemicolectomy or hemicolectomy with complete mesocolic excision technique for right colon cancer involves a resection carried out along embryological planes between mesocolon and retroperitoneum, and along with high or central ligation of vessels feeding or draining the tumor, together with the excision of lymphoadipose tissue along the superior mesenteric vein and head of pancreas, and this concept is known as D3 lymphadenectomy. The oncological principles behind the D3 lymphadenectomy include higher number of lymph nodes are harvested and the removal of an intact envelopes containing all potential routes of metastatic spread, and standardization of surgical technique, which leads to increased cancer-free survival rates. But the therapeutic benefit of removing the mesenteric nodes may be minimal, as there are several confounding factors such as tumor behavior, patient's factor, in addition to the high post-operative morbidity associated with extensive resection. The aim of this study was to examine the short and long-term outcomes of extended surgical removal of mesocolon compared to conventional approach. This was a retrospective population-based study based on a prospectively maintained Danish colorectal cancer group database, including all the Danish patients with a first-time diagnosis of right-sided colon cancer between 2001 and 2018. The data reported to the database group from the surgical departments in Denmark includes the patient's demographics, clinical manifestation, tumor location, tumor stage, diagnostic and therapeutic procedures, and post-operative complications. The present study included all the Danish patients registered in the DCCG group with a registered procedure of right-sided colon cancer from 1st of May 2001 to 30th of April 2018. And data on age, sex, ASA score, tumor location, staging, number of lymph nodes harvested at operation, number of lymph nodes with metastasis and presence of distant metastasis, and in addition to details of surgical intervention, preoperative, postoperative chemotherapy, details of HP examination and postoperative complications were collected. And the staging was performed according to the UICC, that is Union for International Cancer Control TNM system of 5th edition was used as standard in the Denmark, and the Claven-Dindo classification was used to describe the severity of complication. Can anyone describe about the Claven-Dindo classification of severity? If no,
Nikita.
Hello, sir.
Yeah.
So it has 5 grades, sir. Depending upon how we manage the complication, it's graded from 1 to 5. First one being treating conservatively. Second one is treating medically. Third one is any surgical intervention, sir. Fourth one being like some higher level of intervention with like intensive kind of care, sir. And fifth stage is being mortality, sir.
Praveen.
sir. It is
Sure.
used to rank the severity of surgical complication. In grade 1, if it is usually a deviation from normal postoperative course without the need of pharmacological treatment
Show
or
that.
surgical. Yes, sir. I'm displaying it, sir.
It's not visible.
1 second. No, sir.
No.
Original paper is there.
Okay, describe if it is
Yeah,
not
describe
visible.
it.
Yes, sir.
Okay.
In grade 1, there will be deviation from normal postoperative course, but without the need of any pharmacological treatment or surgical or endoscopic interventions. In grade 2, they require pharmacological treatment with drugs such as blood transfusion, IV, TPN, antibiotics. In grade 3, they require surgical or endoscopic or radiological intervention. Grade 3 is classified into grade A, which is done under not done under general anesthesia. 3B done under general anesthesia. Grade 4, there will be life-threatening complications, which may include it may affect the brain also. 4A, it will be described as single organ dysfunction. In 4B, multiple organ dysfunction. Grade 5 is death of the patient.
What
Okay,
is the
continue.
What
Sir.
is the purpose of Clavian-Dindo classification, Nikita?
In order to assess the severity of complications, sir.
No, that you can just say it, no? Patient was severely ill. Patient was in ICU with ventilator and inotropic support. What is the need to classify it as Clavian-Dindo classification?
In order to compare the different types of complications based on one standardization, sir.
That is the word. See, you need internationally acceptable standards so that you are all speaking from the same hymn sheet. If you say class 4A classification is one complication, everybody understands what it is, and so you can compare like for like. So you don't what appears severe to you may not appear severe to somebody else. So if you have a standard classification, then comparisons also will be easier. So if you do randomized control trials across 4-5 centers, you can then have a standard classification so that everybody's complications are listed accordingly. So that is the purpose of this Clavian-Dindo classification. Okay.
And unplanned intraoperative adverse events was defined as inadvertent injury during the operation was also noted. And data about postoperative complications and unplanned intraoperative adverse events were retrieved from the database. And data about local regional recurrence, distant metastasis, mortality within 30 and 90 postoperative days were retrieved from the National Patient Registry. All the patients with right-sided colon cancer, defined as cancer in cecum, ascending colon, right flexure, and oral part of colon transversum were included in the study. And patients who underwent conventional right hemicolectomy and extended right hemicolectomy, according to the guidelines of DCCG, was included in the study. And patient with non-metastatic disease and patient who undergone open laparoscopic, single incision laparoscopic surgery or robotic assisted were included, and patient with elective operation and resections performed with curative intent was included in the study.
Explain.
This figure, this is when right hemicolectomy was done. This is a plane of resection C4, and in the extended right hemicolectomy, the plane of resection is between the C5 and C6, as depicted in this image.
C6 and also C7. That is what the definition, standard definition.
Yes, sir. Here
Extended right hemical. That is what extended right hemicolectomy standard definition is, up to the splenic flexure.
Yes, sir.
What is it based on?
Sir,
That you didn't mention.
in a right hemicolectomy, we'll be ligating the ileocolic, right colic, and the right branch of middle colic artery, while in extended right hemicolectomy, along with ileocolic and right colic, will be ligating at the base of middle colic artery.
Correct. So you include both right and left branch of the middle colic.
Yes, sir.
Yeah. Okay, continue.
Exclusion criteria included the emergency or urgent operation, or patients who underwent ileocecal resection or other types of resections were excluded, and patients who were treated with endoscopic or compromised resection, and who were treated with palliative intention, or with patients with synchronous, metachronous, or recurrent right-sided colon cancer were excluded.
Praveen,
Sir, yes, sir.
go back to the slide. You made the same mistake as they have done. You just pasted it, copy and pasted it. Palliative intention is not, it's yes,
The
not
right
yes,
word,
but T.
right word. Intention.
Intention is TION, but
yes,
then you
TION.
copied and pasted. So exactly the same thing you have written. Okay,
sir.
carry on.
Sir. And the records collected were about 17,174 patients, of which 1,086 patients had undergone palliative or compromised resection, and 1,034 patients had undergone resection which was not clearly stated. So they were excluded. Of them, 15,054 were screened, of whom emergency and urgent surgery were 2,199, which was also excluded. So in the final analysis, 12,855 patients were included, of whom 1,151 patients had undergone extended right hemicolectomy, and 11,704 patients had undergone conventional right hemicolectomy. The primary outcome measure was local regional recurrence, and secondary outcome measure was post-operative complications within 13 days. The data was extracted about the conventional right hemicolectomy and extended right hemicolectomy in the DCG group dataset, and data retrieved from the DCCG database were fully anonymized so that none of the patient data set could be traced, and it was conducted according to the national ethical guidelines, and Danish Data Protection Agency approval was obtained. The summaries were presented with medians and interquartile ranges or percentages, and odds ratio was used to estimate the association between the extended right hemicolectomy versus conventional right hemicolectomy and outcomes in univariate and multivariate comparisons using the logistic regression. And the multivariate estimates were adjusted for various factors such as age, sex, smoking status, alcohol consumption, ASA classification, tumor localization, type of access to abdominal cavity, surgeon's grade of specialization, number of removed lymph nodes, number of lymph nodes with metastasis.
Yes, Nikita. Before Nikita comes in, Praveen, for your benefit and others' benefit, I think Ravi Shankar sir will agree that critique should come in after introduction. Then once you finish the materials and methods and inclusion, exclusion criteria, everything, and then again after statistics. Sir?
Yeah.
Yeah. Nikita.
But here the number of the points that they have studied is less. So I think that is
Less,
why they
ಅದಕ್ಕೆ
included the
yes,
statistics also.
yeah. Nikita, your
Yes, sir.
critique.
Yes, sir.
What are the
The
good points? What are the negative points?
good points are that it is a recent study, sir, with relevant topic.
Okay.
And though they have defined the surgery, define extended and right hemicolectomy separately, they did not mention about lymph nodes, sir. So the inclusion criteria is a bit
No, what I didn't get your this thing. What is your concern?
sir, the primary outcome of this study is to know about the recurrence, and
Okay.
recurrence is so we will get to an idea about it after the lymph node status. So if they are
Lymph node status will
defined,
they will tell us in that results how many lymph nodes they have harvested. That is
yes, sir,
there in the results.
but they did not define anything about lymph node status in the inclusion criteria. Is my point, sir.
Like
So they did not say that compulsory the lymph nodes are being
No,
harvested or any particular group is being.
Nikita,
Yes, sir.
it is standardized that the minimum data set that is required all across the world, how many lymph nodes need to be harvested, it is standardized. So I don't think that is a valid criticism. You just concentrate on what are the good points first.
good points. Good point.
Don't
Even
nitpick.
before going into that procedure, there are so many good points. After that, we'll come to negative points. What is the impact factor? What is the journal where it is published? Is it good or bad?
It is good, sir.
What?
It being a nationwide study is a very pro point, sir.
Okay.
With a huge,
Database.
huge database. Yes, sir.
Yeah, good. And numbers are also good. Like nearly
Yes, sir.
like 12,000 patients. Anything else? Impact factor, is it good or bad?
It is good, sir.
It is
Vinod?
very good actually.
In fact, 4.1 is good, very good.
How much is it, Praveen? 4.7, na? Esto?
Yes, sir. 4.5, sir.
4.5. Okay, that's pretty good.
Yes.
And that SJR is also good, above average. Vinod?
Hello, sir.
Your comments.
Sir, I think positive, all the points were covered, sir.
Okay, negative
Okay.
points then.
Sir, retrospective wise, they are mentioning it as a retrospective study.
Yes.
But these kind of studies, see it's only a retrospective analysis of a prospectively collected data.
Yes, sir.
So, for example, if you are studying, recurrence rates between, let us say, TEP and TAP at 10 years, you have set all the, criteria for what are the data to be collected. At the end of the 10 years, you are doing a retrospective analysis only. You can't do a prospective analysis. You look at all the patients. You would have hopefully, all the data points that you want are there. So always the what shall we say, the disadvantage of a retrospective study will be some of the data points can be lost, but they have actually done something for that. So what is that called?
Registers.
Imputation. What is imputation? Anyway, I think that we will discuss when you come to detail of statistics. But so I don't think that, though retrospective studies are in general negative, this is just analysis of the prospectively, see, the one thing you guys have to realize, having been, in England, the data from the Scandinavian countries are very, very, very rigid and very, very highly thought of because their data collection, because this population is very small and they are extremely rich nations. So their quality of life is extremely good, and hence the data
Denmark,
collection, and it's a
Den
small population. So patients
Denmark
are
data
not going
registry is
anywhere.
one of the good.
Their data is very, very good.
Yes, sir.
Robust data. So I don't think you need to worry about the data as such.
Yes.
What else?
Sir, I think it's a good study, sir. I don't think so much of negative points.
No negative points at all.
I feel so, sir.
Sania,
Sir, ma'am is an emergency, sir.
sorry.
Ma'am is she's on call, sir, today. Ma'am is an emergency right now.
Okay.
She wouldn't be able
Okay. Abdul.
Sir,
No, nothing negative to add, sir.
Sir,
Okay.
if I may, would this
Yeah,
make a
yeah.
difference, sir, that authors are not surgical or medical doctors, but PhDs? So it's just their research study, but not from the medical field.
Need not be, because they've collected, if they've collected all the data, because it is there already in the registry, so they just have to collect. If they have the proper protocol and primary endpoints and secondary endpoints, they just need to assess whether they have all the data and come to a conclusion. So that doesn't matter. Sir?
I don't think that is a negative point. See, and some of them actually may be research scholars who are in Department of Surgery who are currently doing research. That's all. See, after you finish your undergraduation, you do an year or so or 2 years sometimes of surgical. Now the system has changed. What is called as foundation year 1 and 2. I think they're probably similar in Europe also. And before you enter what is called as specialist training, ST1, it may be mandatory in some places, it may be voluntary in some other places. You do a year or 2 of research and get an MD. And if your research is extremely good, you may go on and do a PhD. So you may be a surgeon, but doing research funded by the university or whatever. So I think they may not have actually properly put what their exact designation is, or they may be just doing research. So I don't think that is itself a negative point.
And adding to Sir's comment regarding Denmark data registry, recently in the Hernia Society of India conference, the top surgeon from Denmark, the hernia surgeon, had come. Most of these hernia recommendations and whatever the research papers have been written are from Denmark. So that person had come. So he was talking about he presented a paper on Denmark data registry with respect to hernia, this thing. So what he was saying was they have a like Aadhaar number we have there. They have a number where whatever they do, that single person, whatever they do, they go to the hospital, they take a medicine, everything will get entered into the data registry. So there is no question of missing the data, and most of it will be pretty much accurate. And they've published so many papers based on the data registry there. Sir, any other comments, sir?
Yeah. Even actually to the enhanced recovery program also came from Denmark, from Copenhagen, and the private hospital. I forgot the name. Ersta, I think it's Ersta Hospital, and the data collection was so superb. Every single facet they collected it so well that nobody, when they presented the professor, forgot his name now.
Henry Kellett, Henry Kellett.
Henrik Kellett. When he presented it, he had a standing ovation for 5 minutes. It was such amazing data they presented. So I don't think data collection in all Scandinavian countries, Denmark, Sweden, Norway, Finland, is excellent, and Holland also. So I don't think we need to worry about that. Okay, come on. What is your
Praveen,
critique,
your critique.
Praveen?
Sir, it's as said, it is a recent study and a relevant topic, and there is well-defined inclusion and exclusion criteria.
Just concentrate on what has not been mentioned.
Sir, it's a published in good reputed journal, sir, with a good impact factor and large population size, sir.
Yeah.
Against retrospective study, and the TNM staging they used was of 5th edition, sir.
See,
But
no, that is because majority of the population 2001 onwards to 2018, you can't retrospectively apply TNM staging, the latest TNM staging.
Because the management would have been done based on that TNM staging, which they have used at that point of time. That's why they have used the old TNM staging. So that cannot
Okay,
be
sir.
taken as a negative. But your
Right.
other point is correct, that no defined criteria. They have not mentioned for which patients they have done right hemicolectomy, for which patients they have done extended right hemicolectomy. They have just mentioned that according to DGCA guidelines or whatever. But even if you look at it as per the standard scientific literature, usually extended right hemicolectomy is adopted for lesions near the hepatic flexure or in the proximal transverse colon. Not,
Yes.
it's usually not done for cecal cancers or in the ascending colon, proximal ascending colon cancers. But if you
Yes,
look
sir.
at their data, like still around 20% have been done for cecal cancer and ascending colon cancers. So I don't know whether there was a set criteria or set guidelines for whom they had to do right hemicolectomy and or extended right hemicolectomy. Sir, your comments?
Yeah, I only thing that they say is that some colorectal surgeons doing laparoscopic or robotic surgery believe that the extended right even for standard cecal and ascending colon cancers, and they may have done that. So that is all.
Yeah, but that is
again,
that they
there
have
is
not clear,
they have
no
not
set
made it
criteria.
clear. They have not made it clear.
Yeah. Sir, anything else, sir, is missing?
No, but actually I don't think there is any proof that doing in extended, the nodal. See, the minimum data set is 12 lymph nodes. So if you have harvested 12 nodes, you will get a good idea of whether the nodal involvement is there or not. So below that, there will be an alpha error. If it is, for example, 10 nodes or 8 nodes, you may have an alpha error, what is called as a sampling error. But here, beyond 12, going to D3 dissection and, going up to the superior mesenteric vein and all that, I think it may be to overkill and not adding to the oncologic clearance of the disease. I don't think. So
Correct, sir. So with respect to that also here, the one more negative point is they have not mentioned, even when you have done extended right hemicolectomy, it is with respect to where you ligated the middle colic, but they have not mentioned whether it was a D2 or D3, whether they have gone in for complete mesocolic excision or they have taken the vessel at the root. That they have not mentioned in how many patients it was done, how many patients it was not done, because the morbidity will ultimately depend on that extended lymph node dissection. They will have much more complication rates.
yeah, correct.
Yes, sir.
Go on, Praveen.
Coming to results, out of total 12,855 patients, 1,151 patients had underwent extended right hemicolectomy, and the patients who underwent extended right hemicolectomy were younger males and with a lower ASA scores. Patients who underwent extended right hemicolectomy was associated with significant higher number of lymph nodes harvested and higher conversion rates when performed laparoscopically, and sensitivity analysis where extended right hemicolectomy compared to conventional showed no difference in demographic factors, preoperative characteristics, and postoperative outcomes measured between the two sets of analysis. These were the demographics of
No,
age.
go back. See, the sensitivity analysis, you said no difference in demographics, but then you say significantly higher number of younger males were, chosen to have EHRC. Again, that is a contradictory point.
They say, yes, sir. They said that in EHRC group, majority of them were younger males. But ultimately, they say there was no difference in statistics. There was no statistically significant difference with respect to demographics. So they are contradicting themselves there.
Okay, carry on.
Sir, there is a small thing, sir. they don't mean that, sir. They made 2 sets of analysis from 2001 to 2009 and 2009 to 2018, sir. So between these two, there weren't any change. In the sensitivity analysis, there weren't any differences, sir. There are 2 sets.
I know, I understood that. But even then, this says even in those two sets there is no difference. But they have not said anywhere that there is a significant difference with respect to demographics or preoperative characteristics in EHRC group. So in one point they say there is a difference, and again now they are saying there is no difference.
Okay, sir.
Show the table, Praveen. See here there is no difference in any of the groups. Is there any difference? Hello?
Almost same between the two groups, sir.
No statistical significance.
Statistical.
No statistical significance.
No significance, sir.
Isn't it there in
You-
women
you
and
see at the
it's
time
in
of operation 73 71 for the extended right and 73. So
They say there is difference now here.
there is statistical difference. And women, I think there are more. There is again
More in-
statistical difference. And BMI,
BMI also there is difference.
statistical significance. Yeah.
So age definitely there is then, and women and BMI.
2 years younger. More people in the extended right hemi group. No, I don't know whether it makes any huge difference, but there is.
Correct.
Because in the 7th decade, I think majority of them will have some form of comorbidity. 7th or
And
8th.
somewhere they mentioned that younger population, but here the median this thing what they have given is even in extended right 65 years to 77 years.
So that is not young by any
Young.
stretch.
Yeah.
Even by stretching the European standards, where they call a 90-year-old young man or young girl.
So I don't think so, but that criteria which they are talking about, they are themselves contradicting in one some point of time. Okay, as per the table, there is a difference.
Yes, sir. And
But Nikita, here they have not given that breakup. What you are telling that to 2004 to
Yes,
this thing, and then that they are not given the breakup and they have analyzed.
In analysis, they did not. So in the matter, they just pointed out at one point. Yes, sir.
In analysis, they have not given that to say that there is a difference in that 2001 to 2014, and then there is no difference. Nothing of that sort is given.
Sir.
Hmm.
Yes, sir.
Okay, Praveen. Others
Just
viewers.
go back just to the table.
Last slide. Here also there is some statistical significance. Explain.
sir, in the access to abdominal cavity, it shows statistical significance in the, sir.
What do you mean by
Sir,
statistical significance?
sir,
So laparoscopy was
43%
more.
more in
Laparoscopy
the
was more in extended right
extended
hemicolectomy,
hemicolectomy.
but same time the conversion was also more in the extended right
Extended
hemicolectomy.
hemicolectomy.
But however, open laparotomy was more in right hemicolectomy. I don't know why. Why was that? So basically, again, here coming to one more factor, which is a negative point, is they have not defined the criteria for choosing lap or laparotomy or robo-assisted.
Sir, and shouldn't they be comparing like in extended right like hemicolectomy, the percentage of laparoscopic instead of comparing it with right hemicolectomy, sir? Because as the number of cases in right hemicolectomy is more, there will be statistical significance.
No, in that also they have given percentages, no? So they can tell that in right hemicolectomy group, we have done lap in this many percentage, open in this many percentage, robo in this many percentage. That is right. Okay. But they are comparing the percentages. They are not comparing the exact number.
because there is a huge difference in the numbers.
Used.
See, 1,300 to 11,000. So virtually 10% of the 10% of the cases only they have done extended right. 90% they have done right hemicolectomy.
Yes, sir.
But open surgery for right hemicolectomy, actually lap and robo is much more easier for right hemicolectomy. There they have done more numbers of patients in right hemicolectomy group. They have done open procedure. So that is one negative point where they have not given us the clear-cut guidelines for which patients they had to choose open lap or robo assistant, or was it a surgeon preference? Because
So this,
ultimately our complications also and outcome like wound infection, wound essence will all ultimately depend on those factors also.
so this
Sir.
is the different. This is the problem with retrospective study, because this is they didn't know that they have to stratify according to these things. So they have just collected data and shown the data, but the explanation as to why the data was collected, this one the procedure was done. So if you actually had done a prospective study, you would have told, for this group of patients we will do laparoscopy. For this group of patients we will do robotic surgery. For this group of patients we will do, or you randomize them and then study them as they go along. So either you randomize them and you just take the results as they come, or you define set criteria, as Niranjan said, define set criteria as to when you do what procedure and then follow it prospectively. So that is the advantage of doing prospective studies. Here, though the data has been collected prospectively, they are retrospectively analyzing it. So hence certain questions as to the indication for doing a particular procedure has not been clarified. Carry on.
And also that the surgeon's grade of specialization, there is significant difference where colorectal surgeon has operated in around 90% in extended right group, and it is only in 75% in the other right hemicolectomy group.
Yeah.
And also and also with respect to tumor location. So cecal cancers have still been operated, and also ascending colon for extended right hemicolectomy.
And if you look at the number of nodes they have harvested, it's significantly high in the extended right, but in terms of the node positivity is not different. So it is probably a waste in trying to do too much.
Correct.
With no oncological advantage, so to speak.
And also in if you see, there is in 7% nearly in right hemicolectomy group they have done it for transverse colon, where the question of margin comes in.
Okay.
Where you ideally had to do a extended right hemicolectomy.
Yes, sir.
Okay, continue.
Continue.
Coming to local regional recurrence, the rate of recurrence in the whole material was about 1.5%. That is 249 patients among 17,174. And after the exclusion of cases according to inclusion and criteria, the recurrence was about 1.1%. That is 136 cases out of 12,855. And there was no difference noticed between the conventional and extended right hemicolectomy group. And the location of tumor had no effect on the local region recurrence rate.
Explain.
This is the table.
Where you
Yes, sir.
remind.
In the around 21 patients had a local recurrence in the extended right hemicolectomy group, and 115 patients had a local recurrence out of 11,589 patients.
Sir, I have a doubt here, sir.
Yes, Nikita.
What does that plus and minus mean, sir? I tried a lot, but I couldn't understand the whole table, sir. What does surgeon and ligature mean also, sir?
No. See, they have
Plus is present.
to avoid bias and this thing. When they try to define what is extended right and what is right hemicolectomy, they have taken 2 points into consideration. One, where the surgeon has said that he has done right hemicolectomy as per the what is it, ligature. Okay, and the other one is with respect to this one. What is it?
Anastomos.
The form, DCG registration form, they would have written it as extended right, but in the findings they would have written it as ligation of something else. So they have tried to club both the findings to minimize one group overlapping into the other group. So they have set 2 points criteria. One, DCCG registration shows that the operating surgeon has mentioned it as a extended right hemicolectomy, and they have also double checked by noting the findings of the ligation of the middle colic vessels.
Okay, sir.
You understood? That is to avoid bias, like one group underreporting or one group overreporting. They have included both criteria to define it as extended right hemicolectomy.
Got it, sir. And plus and minus, sir.
Plus is present in this group and negative is no.
No complications in the group. You understood? Post-operative complications out of the 1,000-something patients in each EHRC, 291 had complications, 860 did not have any complications.
Okay, sir.
Understood? No.
Yes, sir.
Okay. Yes, Praveen. No, you didn't
Sir,
you didn't mention which was significant.
Sir, both of the percentages were same in the both groups, sir. 21 out of 1,130 and 115 out of 11,589 had the same percentage of recurrence.
No. Anything statistically significant in them?
0.014 is significant, sir.
Where? Which one?
Sir, in the post-operative local recurrence, sir. The right side table, sir.
No, you're talking about complications. No, here.
So, the left side is complications and
what you're showing is complication slide.
Sir, and this is on right side is a local recurrence, sir.
Where right side?
Right side table, sir.
No. First explain the first table, man.
This one, sir. Post-operative complications. There was no significant changes in the both groups, sir. According to this, only medical complications they have given us significant, sir, with the 0.03, and post-operative 30-day and 90 mortality is significant, sir.
Okay.
So that
They
means
don't add up, sir.
So that means you have a higher mortality and morbidity in the extended right hemicolectomy for no oncological advantage. Is that what they are saying, Praveen?
Yes, sir.
Sir, there is a ambiguity in that also, because in the explanation they say it is not so. It is not like that. I don't know how to interpret this data.
Sir, and they mentioned as post-operative complications all being 291. I mean 291 present in extended, but surgical and medical together they are more than that. So like 350.
No, so many patients may have both medical and surgical. No, overlapping can be there.
One patient may have 2 or 3 complications.
So that is not the thing. Here, yes, sir.
If you look at the odds ratio is not that, very absolutely clear that there is a definite difference between the two groups.
Correct.
But the odds ratio still favors the right hemicolectomy, classical right hemicolectomy compared to extended right. That's all. But So if you infer from that, you can say that despite doing an extensive surgery, it has probably given them more complications, may not be that significant statistically, but with no oncological advantage. So that means you
Right.
don't do extended right. That is the message.
Correct.
Yeah.
Go on, Praveen.
Sir, in the local recurrence also, they have given us p-value 0.014, sir, which is significant. But the percentage of recurrence is same in both the groups, sir. Extended and the conventional.
See,
No,
the
then
recurrence,
there is no statistical significance.
recurrence rates are
Sir.
very low, man. 1.1% is nothing. It's very good. So it's excellent results. That's not a problem at all.
Okay, sir.
Go on.
Carry on. Next slide.
Coming to
What
post-operative
is the last
complications.
table that you skipped?
So it's a multivariate analysis of they taken of number of cases done in the cecum, ascending colon, hepatic flexure, and transverse colons.
So what do you understand by univariate and multivariate analysis, man?
Sir, univariate is analysis of single variable, sir. In multivariate, there will be more than two variables. So, and
that is
multivariate analysis.
self-explanatory. But what is the purpose of doing univariate analysis and multivariate analysis? Nikita?
In order to make any association between two.
Correct. See, Praveen,
Sir,
when there are many factors which may impact on the complications, morbidity and mortality, let us say diabetes, age, alcohol consumption, and whatever, so, or disease, for example, in cecum. So whenever there are many factors which possibly impact on the final outcome, you do a multivariate analysis to see which of them have statistically significant difference in terms of impact, as opposed to something which is just it may be there but not so significant. So for you to target what are you going to change, let us say, if you want to study a particular disease and see which are the factors that impact on it to a significant extent, then you can try and see if you can modulate or intervene. Let us say if somebody who is smoking, you stop smoking for a month and then see whether that cessation of smoking for 1 month has made any difference in terms of the overall outcome. So that is the advantage of doing multivariate analysis, as Nikita said, to understand the differential impact that the multiple factors may have on the outcome.
Yes, sir.
So what was the impression there?
So post-operative complications are higher with the cecum as opposed to, or with ascending colon as opposed to cecum. Is that the inference?
They're given statistical significance, but we can't. I don't know how to interpret it because there are more like cecum, ascending colon, hepatic flexure, and transverse colon. All four they've clubbed it together.
Sir, even the recurrence rate they have it is mentioned as not significant, sir. Sir, even for the transverse colon, if they are doing the surgery like hemicolectomy, there is. What about the recurrence, sir? If it is not significant,
That's I think Niranjan commented on that before. See, again, as the only problem with that is that it is just a retrospective analysis. So the criteria to do standard right hemicolectomy, extended right hemicolectomy has not been actually because it's not a prospective study. There is no protocol. So you are just collecting data and interpreting it. So that's the problem.
Yes.
Okay.
So it is difficult to pinpoint and tell anything like significantly this based on this data.
And so I think subgroup C always, all of you have to understand. See, in statistics, if you do what is called as post hoc analysis or subgroup analysis, that means your primary endpoint, whatever you are studying, has not been statistically significant, or you have not been able to show the difference. So then you try and do subgroup analysis, post hoc analysis, and try to show that there is difference. So that is usually, some industry driven. For example, you are testing two meshes, one proline mesh and another this proceed mesh or whatever. The industry is driving you to show some difference. So when you look at the five-year recurrence rates, there is no difference. Then they may come up with, let us see if there is any, some, seroma or whatever small thing, and then say the proline mesh is inferior to the proceed mesh. So that is called subgroup analysis or post. They are not the same, but post hoc analysis. That is, you had not planned that particular analysis in the beginning, but then once you saw that your primary endpoint is not reaching statistical significance and you're not able to, make any important recommendation, then you do this post hoc analysis and say, in this particular group, the proceed mesh is better. So this just to show that proceed mesh is better. So that this is also like that. So when you do what is subgroup analysis, post hoc analysis, beyond the accepted endpoints, then you may show some difference. So you don't take those differences seriously. Okay. So you have to stick to define what is your primary endpoint and secondary endpoints and just, interpret them. The other subgroup analysis and all that may be just, just to satisfy or to show some difference or whatever it is.
Yes,
Yes, sir.
Praveen, continue.
Continue.
Coming to post-operative complications, there were higher rates of complications when associated with extended resection. After adjusting for covariates in multivariate analysis, there was no difference shown between conventional and extended right hemicolectomy in rate of overall 30-day postoperative complications and 90-day postoperative surgical complications. But medical postoperative complications were significantly higher in extended right hemicolectomy, even after adjusting for age, comorbidity, access to abdomen, and other confounding factors that were significant in univariate analysis. But there was a mismatch between the data given in the table and in the results, sir. Here in the medical complications, it was actually more in the right hemicolectomy according to data.
Praveen didn't know 4.5 pneumonia.
First table is the total number, second is extended hemicolectomy, third one is the right hemicolectomy.
Huh.
So, according to this table, more numbers were in the right hemicolectomy patients.
Hmm.
And another thing is, most of the data from the extended right hemicolectomy was missing.
Hmm. Okay.
In other results, there was no difference noted between the conventional and extended right hemicolectomy.
Critic, we have already
Sir,
done.
here,
So,
We've already
here
done.
I had only one point. You go back, Praveen.
Praveen,
sir, yes, sir.
what you had sent me did not contain all the statistics, man. It is just all the theory. So
I have
actually,
sent, sir.
I thought
It
I know you
was
had sent. But somehow when I opened it, I only saw Just the theory, the tables and things were not there.
It was in the last, sir. After
Oh.
the reference, they have given the tables and pictures
Oh,
form,
okay,
sir.
okay, okay. Okay. Usually the tables are, accordingly, slated according to the description.
Yes, sir.
It's a bit unusual. Okay.
Hello.
Yes, Niranjan. Hello.
Hello.
Niranjan, you were saying something. One point.
Hello.
Yes, sir. Audible, sir.
Praveen, am I audible?
Sir, yes, sir. You're audible, sir.
Yeah. So in that, no, not this. Go to your points later. Before I think before this. Yeah, here I couldn't understand what they're saying, trying to say in the second point. Hello.
Sir, yes, sir.
Yeah. I was asking Ravi Shankar sir. How to
See, I
explain
think
this.
basically,
Second.
see, the thing is what they have done is that they are looking at the possible causes for the post-operative complication differences between, and then they looked at all the factors that may impact on that, and then even after doing a multivariate analysis, they have not been able to show any difference. That is what they say, but there is actually a difference between the two groups.
Two groups in
If
the
you look at
data
the table.
table. If you look at, there is definite
Definite
difference
difference.
between the
So
two
I don't
groups.
know
So how
what
to
they're.
explain? I don't know. And
I
also one
think
more
their
point.
inference drawn is not commensurate with what they have found.
Tables. Yes, sir.
And also, if you look at the data closely, a number of missing data points like missing wound infection, missing post-operative
UVT,
anastomotic leak,
it's
missing
quite significant
immune
number.
is quite significant. And that too, if they have taken from the Denmark data registry, where the data going missing is like very like highly unlikely. So a large amount of patients have a missing data.
See, intra-abdominal abscess, there's about 46% missing data. For post-operative bleeding, that is not so much. For other surgical complications, 42%. And for myocardial infarction, 30 and 87%. And again, for aspiration, 87%. DVT, 87%. So there's a significant number of patients where the data is missing.
Yes, sir.
Post-operative sepsis, 87% data is missing. So I think difficult to draw some of the conclusions.
Sir, and in theory, they mentioned about comorbidities, sir, that they were comparing comorbidities, but in data, we couldn't find any
Yeah.
information with them.
Smoking, alcohol consumption. They have compared it.
Comorbidities.
Yes. Comorbidities also they have not mentioned. And one more important thing is they have not mentioned about the follow-up. When have they after how many months till how many months they have followed up, and when has the patient developed local recurrence? Those data is also not that data is also not given. Yes, Praveen.
Yes. Okay. Carry on. We have discussed almost all of them.
Yes, sir.
Next page.
Coming to discussion, according to this study, the study showed that there is a low local regional recurrence rate with no difference between extended right hemicolectomy or conventional surgery. And they showed that extended right hemicolectomy was associated with higher complication rates. Usually, the local regional recurrence rates after curative surgery for colon cancer is reported from 2.1% to 25.5%. And any model to understand the local regional recurrence must have the factors which include patient's demographics, genetic or epigenetic characteristics, anemia, presence of sarcopenia, surgical stress response, bowel perforation, and postoperative enhanced recovery pathways, which play a significant role in recurrence. And tumor biological behavior is considered as a prognostic factor because of its role in metastasis. And tumor characteristics like budding, extramural venous invasion, lymphatic and nerve invasion, in addition to tumor immune microenvironment, also determine local regional recurrence. And there are many confounding factors such as lymph node retrieval, including patient age, immune status, tumor location, and characteristics. So, the removing large number of lymph nodes to decrease the rate of local regional recurrence is therefore a hypothetical unproven concept. And there was finding of high postoperative complications in extended resection group, which is in line with the published systematic reviews and meta-analysis. And it showed that extended resection is to be associated with greater intraoperative blood loss and more of postoperative complications. And due to the extensive surgical dissection along the major arteries, there may be the damage to autonomic nervous plexus in close vicinity of the vessels, leading to poor functional outcome after extended right hemicolectomy. And there are several other factors associated with local regional recurrence, such as emergency surgery, bowel perforation, surgeon's competencies in colorectal surgery, and advanced tumor stage. So, the overall survival of colon cancer patients who develop local regional recurrences after the initial treatment is generally poor. The conclusion of this study was the results of this large population-based registry showed no difference in local regional recurrence of right-sided colon cancer between conventional and extended right hemicolectomy, with mesenteric resection and ligation of middle colic vessels. However, there was extended resection showed was associated with higher rate of postoperative complications compared to conventional resection.
So, Nikita, what is your take-home message?
Sir, if the surgeon is
Hello?
Hello,
sir.
Nikita.
Yes, sir. Depending upon the location, we choose extended right hemicolectomy, sir. But
No, that is not the take-home message. You know, I'm not talking about what
Sir is
you have to
asking
tell
take
me what you understood from the paper, not
not
what
for
you know.
theory.
there is no difference in metastasis or recurrence based on the surgery.
No, they're not talking about metastasis because they have not even studied the metastasis here.
Recurrence, sir. Mainly the
Local
recurrence. Local recurrence.
So you can you conclude by whatever the data they have shown?
No, sir, because there are a lot of discrepancies. I couldn't exactly conclude.
So basically, there is no advantage. That much we can conclude from whatever this thing, that doing an extended right hemicolectomy does not give any oncological advantage, with probably with more amount of complications. But as per this paper, that is what we can conclude. But there is lot of discrepancy in what the data they've shown, and there is lot of data missing, and there is lot of discrepancy what is there in the table and what they have written there.
Yeah.
Sir?
Yeah. I think you've done everything perfectly correct. So the take-home message would be that extended right hemicolectomy or standard right hemicolectomy has to be chosen by the surgeon according to the site of the tumor rather than its perceived advantage of giving better oncological clearance or survival. So as somebody said, if it is a hepatic flexure or a transverse colonic tumor, you are it makes sense to do a extended right because it is more oncologically sound. So apart from that, I don't think just doing an extended right for everything is necessary. So no oncological advantage. And complication rates, obviously if you are doing an unnecessary nodal dissection in very significant and sort of very critical vascular areas, See, superior mesenteric vein is a very difficult structure. Once it starts bleeding, even if you control the bleeding and and repair the thing, it is then prone to developing thrombosis and all those things, which will then obviously determine the post-operative survival of the patient, complications, and also the quality of life and all that. So hence, unnecessarily doing extended nodal dissection is probably not necessary. That is the message from this paper. Whether obviously it makes sense to think that more complications will happen if you do a more extensive procedure. That is a necessary corollary of the paper. That's all I can think of.
Yes, sir. Praveen, you have any
Sir,
other
yes, sir.
data to show us from any other
Yes, sir.
papers? Anything
Yes,
in
sir.
the literature? Yeah.
Yes, sir. A paper by Proziska, which was based on complete mesocolic excision during right hemicolectomy. 83 patients were included, out of which 63 had a standard procedure and 20 had undergone hemicolectomy with the complete mesocolic excision. The results were the operation time of right-sided hemicolectomies with complete mesocolic excision was longer by 20 minutes on average, and the incidence of lymph node metastasis was similar in both groups, but the total number of removed lymph nodes in the group with complete mesocolic excision was significantly higher.
Okay.
And in another study by Wang, which was based on safety, quality, and effect of complete mesocolic excision versus non-complete mesocolic excision in patient
Praveen,
with colon
one
cancer.
minute. This is different. Complete mesocolic excision is different. What we are talking about is right hemicolectomy versus extended right. This is what you are talking
Yes,
is complete mesocolic and non-complete mesocolic. That is different, totally different.
Okay, sir.
Tell us anyways. Okay.
So, in complete mesocolic patients, there is positive effects on 5-year survival, 3-year survival, and 3-year survival for stage 3 when compared to non-complete. And complete mesocolic excision was associated with greater intraoperative blood loss and more postoperative surgical complications.
Okay.
Again, you
This
are
was
talking about the same thing,
uh,
Praveen. Where is the data on extended right hemicolectomy? We wanted data on extended right hemicolectomy.
God, I mistook as complete mesocolic excision as this one, sir.
Okay. Tell us.
This is a meta-analysis by Tamara and based on complete mesocolic and then conventional colectomy. In this, post-operative complications were higher in complete mesocolic group, and there was no differences in terms of anastomotic leak or perioperative mortality. And in complete mesocolic excision, there was higher number of lymph node harvestation, and there was distance to height, bowel length, and mesentery area. And it showed positive effects on 3-year and 5-year overall survival rates.
Yes, Nikita.
Yes, sir.
I think Ravi Shankar sir had summarized that last time, like when he spoke. So it
Yes, sir.
is, we will not change our practice based on this study, but based on the literature, whatever we know, I think we should base the decision of doing a right hemicolectomy or extended right hemicolectomy based on the location of the tumor rather than going for a greater oncological clearance, even in irrespective of the site of the tumor. Sir,
No, I think that is
your final comments.
that is the and to talk about Praveen, I think I'm very happy. Praveen has, I think, he presented very well. He seems
Yes,
to
sir.
have understood this one subject well, and he's putting the effort.
Except the literature, Praveen.
Yeah.
Yes, sir. Yes, sir.
You got confused. That is, the complete mesocolic excision is totally different from what we were talking
Extended,
about, right
yes,
hemicolectomy and extended right
Right.
hemicolectomy.
Yes, sir. Yes,
So I think continue the good work, Praveen. I think you are improving well. So good luck, doing well.
Yes, sir. Thank you, sir.
Sir, I think we'll conclude then
Yeah.
if no other
Okay.
questions or comments. Anything else, Anya, Abdul?
Abdul, any questions?
Comments?
No, sir, nothing to add.
Sanya, are you there or are you still in emergency?
Madam is not there still.
Okay. Right.
Okay.
Okay.
Thank you. Thank you. Good night.
Thank you, sir.